Hello, y'all. So, welcome back from spring break. Now, you might not watch this for a week or so since you're doing the anatomy portion, but we're gonna do a quick video. I'll try to be quick. You guys know I'm long-winded, but we're gonna do a quick video on the thorax and some of the protocols of the thorax, the more common ones. There's a lot you're gonna run into, so I'll just give you a quick run through of just verbally here, and then we'll get onto the scanner and we'll look through some of the protocols and how they may differ, so that you can get a glimpse of what that might be like. Again, if you noticed from the last discussion board you did, every facility is going to have a different version of a protocol to demonstrate similar things, okay? So it's not really about right or wrong, it's about understanding why we do what we do. All right, so when we talk about the thorax, we're talking about the chest, okay? So we're scanning from above the apices through below the lung bases, and in many facilities they scan through mid-kidney so that they can include the adrenal glands. And I was told by a radiologist that they do that because often lung cancer can metastasize to the adrenal glands, okay? So there's various pathologies, innumerable pathologies that can occur within the thorax, all right? So some of the indications for different tests are this, right? So if I'm gonna do a chest with contrast, then obviously I'm looking for metastatic disease or primary cancers of the lung. Maybe I'm looking at this odd pneumonia and they're trying to distinguish it from cancer, or any strange pulmonary nodule or things like that that might show up. I'll probably do a chest with contrast. If it's a new nodule, it would be chest with contrast, like if it showed up on a chest x-ray. Oftentimes you do a chest without contrast to track the progression of a pulmonary nodule that's been there for a while and they want to make sure it's not growing. So maybe you do it every 6 months, every year, something like that. So your general pathologies of the chest, you're going to do a chest with contrast. That's kind of the go-to. Unless contraindicated, we're almost always going to do a chest with contrast because the chest is inherently you just got lung, you just have air, right? So there's not a lot. You do have the parenchyma and stuff like that, but you really have all that vasculature, and you want that to have the iodinated contrast within that vascular structure so that you can see it, okay? So most of the time it's going to be done with contrast. Now that's your general stuff. Other things you might look at that are very common are pulmonary emboli. Now, you probably know what that is, but a pulmonary embolism is a blood clot within the pulmonary arteries. And it's really important on your CT, and as you move forward and study for your registry, is that you're very familiar and you have a good understanding of the vasculature in the chest. So the flow of the heart, the directions that those things go, and so on and so forth. All the branches off the aorta, you're going to get tested on all that, so know it, okay? Yeah, so we've got pulmonary emboli. That's a specific protocol. It's pretty neat. They're beautiful pictures, so we'll get into that and what that looks like, but that's a pretty standard deal. So basically they come into the ER, they have chest pain, difficulty breathing, low oxygen saturations, and an elevated D-dimer. Ding ding, pulmonary embolism. Like I just got one ordered. I'm waiting on them to draw another creatinine. So there we are, okay? They're really common. You'll do them daily. Another thing you might look for, which is a little more rare, is if they have like penetrating chest pain that goes from the front to the back, and it's just the worst chest pain they've ever had in their lives. They don't have an elevated troponin, so it's not a heart issue. They might order a CTA. So a pulmonary embolism is technically a CTA. It's an angiographic study, but it's the pulmonary arteries are different. They're a different timing because that's actually unoxygenated blood moving out to the lungs. The veins carry the oxygenated blood back, so that's a quirk of the pulmonary system, right? So on a CTA, that's like a true angiogram, we're looking at the aorta and trying to see if there's a dissection of the aorta, okay? So those are kind of your three main ones in the thorax that we're going to look at, all right? You get a chest with contrast or without if there's a contraindication, like a pulmonary embolism, pulmonary nodule. So that's kind of our general standard. Then there's the PE, which is also incredibly common, and then there's the CT angiogram of the aorta, or the thoracic aorta, which is another study we do. So we'll kind of talk through each of those, and then we'll jump into it. So here we go. Okay, so let's talk through some normal chest. We're going to start with the most common, a chest with contrast, okay? This is an anonymized scan. It's a real scan. And we'll start as if we were going to do it. Now, if you reference your the first video I shot on the neuro stuff, you'll remember Claire was going in feet first supine, and we were putting our inside laser light above the apices. Okay, so just mid neck, like you would like C4, so like for cervical spine X-ray, right? And so then we load our topogram and we start it, and it scans from here through here. Now, our region of interest on a chest, if we look at this one, it's actually more than what we would want. So let's look at our scan parameters. So the first thing I'm going to do after I get my scout here is I'm going to set up my box. So this is going to be my scan field of view that I'm aligning here, this pink box. So what I would do is I would put that above the apices, maybe not quite that high, because all these extra slices do over time amount to extra dose. Maybe pull that down some, and then this one down here, I'm really only trying to get through the mid kidneys. Now we can see the full liver here, so we've got most of this kidney, and the left kidney is typically higher, so I would more likely be at L1 as opposed to L4 down here. Okay, so they really did over scan on this patient. It looks, well, here's mid kidney. You want through the adrenals for most protocols, and the adrenal glands are like this upside down Y here and that thing there. Okay, that one. So maybe they did go far enough. One little hack on a Siemens scanner is if you're not sure where to stop, open the field before, and then there's a little button on the control panel, like way up here, this little thing here. You can abort the scan once you see your destination over here on the right where my cursor is at. Okay. Anyway, so I set up my box. Then I'm going to put my pre-monitoring slice right here. This is my pre-monitoring slice. This is where I take a single picture so I can start my bolus tracking. So I've set up my box and then my pre-monitoring slice, and it's going to be at the carina. So if you notice, the trachea is here, and it bifurcates into the right primary bronchus, left primary bronchus, the carina is here. We set the pre-monitoring slice there, we take a single picture, at which point we get this image, okay, on the right. So then I click within here to place my region of interest in this vessel. This vessel is our descending aorta. And we'll just take a quick sec, because it's important that you recognize each of these vessels that we're looking at here, okay? So we have our descending aorta posterior into the patient's left. We have our ascending aorta anterior here. So if you were to look at this, if we were to scroll up a slice or two here, which you can't because it's a single slice, but what you would see is that this is where the arch starts, and it comes off of the left ventricle. It crosses under, comes off the left ventricle, travels superiorly and then posteriorly, and then hooks back to the descending aorta, which goes down and then feeds the whole body with oxygenated blood. So this is the ascending, descending. This is our pulmonary trunk, and that's one of the branches, the right pulmonary branch, and the left one looks like it might be inferior to this, and it's going to swing down this way. And if we could scroll through, we'd see it. I'll show you when we look at the actual scan. And then inferior to the trunk, we're going to see pulmonary veins coming in. We can see the bronchi bifurcation here, right? The primary bronchi here and here, and you can start to see some of it here. So there's a lot of cool stuff you can see on this picture. If I window and level it, we might even get some lung parenchyma. Yeah, you can start to see the lung tissue. So it's pretty cool, right? Anyway, that's our pre-monitoring slice. We place our ROI in the descending aorta, and then we have our monitoring that's going to start. So then what we'll do is we're all set. Our scan range is set. Our monitoring is set up for our bolus tracking. And then we just start our injection and start our monitoring. And then the monitoring, if you click here, look here, is going to count down, let's look, 10 seconds. You can see delay 10 there. Maybe you can, maybe you can't, but it says 10 seconds under the delay right there. It's going to count down 10 seconds while the injection is going in, and then it's going to begin to take pictures right in this location. So if we look, here's our first image. It measures 37 Hounsfield units after 10 seconds of injecting. Then another second later, it's all the way up to 60. You can see the pulmonary vessels have already filled, or the pulmonary arteries here. Another slice, it's at 118. Now this monitoring slice, if you look at the bottom, is set to trigger at 100. Well, again, we had this last time. Anyway, this is set to trigger at 100. So when it hit 118 right here, it started the scan. So we've got 10-second delay, 1, 2, 3 images. We're at 13 seconds, okay? Then we look at the chest. The chest is going to count down another 10 seconds. So for this scan, it began 23 seconds after injection. Right now, typically a chest, if you weren't going to bolus track, you could scan the chest at 25 to 35 seconds and be okay. Bolus tracking is amazing because it specializes. All right, so then this is what we get. So we start scrolling through and we can see a beautiful chest CT. All right, now you guys are going to need to be able to identify all of this anatomy. And I know that's what you're going to be doing this week, this first week of this section, is creating these and labeling these and all that jazz. So you'll want to know all these. Every vessel in here is up for grabs. Every portion of the heart, the ventricles, right, the left and right, and all that jazz. You need to know it, and then even once you get down into here, okay? So that's like how the scan will go. The whole procedure isn't gonna take 10 minutes. Like you lay them down and it's just bing, bing, bing. So let's dig into this protocol a little more. Let's look at what the chest looks like when it's scanned, okay? Let's go, we've got our routine tab here. I'm gonna come up closer and just on that, so maybe you guys can look just at the routine, or these tabs. That looks good. All right, so we've talked about this before. So the scan time is going to be based on the range that we set up initially. Okay, so this range over here, that's how many slices we're going to acquire, and that's what our scan time, it came out to 7.8 seconds. If we look here at the slice, you'll see that this is using 1.2 millimeter detectors. And they're using 32 of them, which is going to give us like our z-axis coverage for this scan. That's going to affect dose. You guys should probably understand that by now. If you don't, make sure you ask me. And it's also telling you what the CTDI is going to be based on all this information, and the dose length product based on all this information. So that's pretty awesome. It's all right there. Note the reconstructed slice thickness is 5 millimeters. Okay, so acquired at 1.2, reconstructed at 5. What this means is that I can go back as long as the raw data is available, and I can reconstruct all the way down to 1.2 millimeters. This scanner does have an option to allow me to go to 0.6 millimeters. Okay, so just keep that in mind. When you guys are creating your protocols, it's perfectly fine. Like if you're going to give the slice and the acquisition, here you go. It's just laid out. If you have a Siemens, you can just check that out on any of the scans at your facility that you're going through, or Google it, whatever. Text me, it's cool. And then there's some annotations, 80 cc's of omnipaque. That's how much contrast we use for chest. We found that chest don't require as much as an abdomen and pelvis. We use 80 cc's of 300 for your standard chest, and 95 of 300 for your abdomen and pelvis. Okay. Again, you can notice this little dude over here. This is feet first supine. It's just indicating the direction of the patient, the position. All right. Let's see if there's any other information. Now, this is important. We do a pitch of 0.7 on our chest. So that's lower than 1. So we've got some overlap there of our slices. So as our z-axis coverage scoops around those 32 detectors that we got, as it scoops around, boom, there's gonna be some overlap there. This is all repeat information, and then finally we have our reconstructions. Okay, so our kernel here on the Siemens scanner that our radiologist decided on with our application specialist when this was installed is B30F medium smooth in a mediastinal window. Okay, and then here, this field of view, this is not our scan field of view, right? This is our display field of view, which we manipulate when we change the size of this box when we're setting up a scan. Okay, so that we don't type the numbers in. GE is very number focused, whereas Siemens is like a graphic interface, a user interface. So it's a little more intuitive. Anyway, so there we go. And then that's that scan. So straightforward and simple. Now we do coronals with every chest at our facility. Now some facilities are gonna wanna do coronals and sagittals on all of them. In fact, if I had to send this to Telerad on an overnight to like VRC, the virtual radiologist, I would have to put some sagittals on. So different doctors have different preferences. And I know it might drive you crazy watching me scroll back and forth, but as you study your anatomy for these things, this is how I would encourage you to study. If you get your hands on a CT, scroll back and forth. Find a structure like here's our ascending aorta, right? We saw it on the axial. You can look over here and it verifies on the axial where I was talking about. Here's our ascending, and then as we scroll posteriorly, like I said, it goes superior, and then it swings down. and there's our descending aorta over here, right? Okay. Anyway, so again, be familiar with the anatomy, but these are beautiful pictures. We can throw this thing in a lung window, but look at that sternum, all right? You'll never get that on a radiograph. It's freaking gorgeous. But say we wanted to do a sagittal real quick. I'm selected here. I still have the raw data for this, so I'm gonna add a reconstruction. It's gonna take me to our 3D reconstruction window here. I'm gonna back out so you can see it. So this is my sagittal image. You guys, I can't teach you how to do this, but I'm gonna go ahead and do it and show you how fast it is. Right, so there we are. Now it's a sagittal. Bring it on in, and then there it is. We got 5mm slices with a 5mm increment. It tells us how many images. We got an NPR. Let's do a MIP for the hell of it. There we go. That's more for PEs, but we'll go ahead and do it on this, and then we're just gonna come over here, hit the recon tab, and it's gonna spit it out. It'll take a little bit. You can see it's thinking down here if you look at this little box, but we'll let that spit out, and then we will jump on over to our next study, which is going to be, we'll go ahead and do a pulmonary embolism. There's our sagittal. You can see it popping up that quick. It's gorgeous. And remember, this is a MPR, or a multiplanar reformation. A lot of times you guys are going to hear me mix recon and reformat up and use them as synonyms. They are not. I looked at your midterm. It looks like each of you understand the difference, but still, look how cool that is. So if you wanted to see the aorta, this is a money shot, right? It's gorgeous. To see the descending aorta, you can see the calcifications in the aorta here and here, those bright white spots. You can see the sternum. So like if this was trauma, our standard protocol would also include sagittals, because you could put this in a bone window and see the T-spine, all this stuff, okay? So just a massive amount of information that you get from a CT. So no wonder physicians love it. All right, we're gonna jump over to the PE. Okay, so this is a pulmonary embolism study. These are tricky beasts to scan because they have to happen perfectly the first time. You inject incredibly fast, anywhere from 5 to 6 milliliters per second. So your bolus just flies in the patient, and you have a very limited window to get it. So everything kind of has to happen perfectly for these to be good studies. So I don't know what this one looks like, to be honest. So we'll see if this is a beautiful study or not. So there's a lot of moving pieces. I want you to first just take a look here where it says, tell the patient not to take in a breath, just stop breathing when told to. So what we ran into is we found that the machine comes on and says, take a breath, hold your breath. What that was doing was actually increasing the pressure within the thorax and squeezing the contrast out of the vessels of the pulmonary arteries. And so we weren't, it was washing out our PE studies, and they didn't get these big, bright, beautiful pulmonary arteries that they need in order to diagnose a clot within the pulmonary arteries, okay? So that's the first thing. But yeah, so I'm gonna walk you through the protocol. You set it up just like you would for a regular chest. You get your topogram. Now, the next thing that varies, you set your range up as well. Now, let me go ahead and talk about that range real quick. So this is different depending on where you're at. So a PE, traditionally speaking, actually doesn't need the entire lung field. You really only need from the aortic arch through the lung bases, and then you're covered. But we recently changed our protocol, so now and this is kind of a COVID thing, because they were ordering a lot of PEs for patients with COVID. So they wanted to, since we were doing a CT of the chest already, albeit with different contrast timing, they wanted to see the whole lungs, right? So, all right, so we set up our scanning range, then we go to our pre-monitoring slice, which is this orange slice here, and then we come over. So I want you to look here at this picture. Now note, on our regular chest, we had, I'm sorry, clear my throat. On our regular chest, we had our ROI here, right, which was in the descending aorta. Again, we have descending, ascending, and the pulmonary trunk, which is here and then crosses for each branch of the pulmonary trunk. So this is bolus tract right here, okay? Now, after this point in the scan, your protocol is going to vary at every facility. It's varied at my facility, okay? So I'm going to show you this protocol. This one is called PT3. Let me double check and make sure I got that right. So look at my, sorry, broke my homemade tripod here. Look at my angio protocol. So P3T PE. So if I select this protocol on my, this is my MedRad if you don't recall, it's going to be based on weight. So say I have a 250-pound patient. I'll say, okay, it's going to give me, these are the scan parameters. It's going to say we're going to go in at 6 cc's a second, which is really fast. We're giving Omnipeg 350, which is very viscous, and we're going to give them 52 milliliters, and that's all. Now, check this out. If I go back and say, let's do another P3T, this patient is only 120 pounds. So look how vastly different it is. Now I'm only giving them 36 cc's at 4.5. All right, so what we found is this particular injection protocol mixed with the timing sequence I'm gonna show you gives us the most consistently diagnostic pulmonary emboli studies, okay? Again, like I said, it's like a one shot, so we really gotta get it right. All right, so we have our pre-monitoring slice. We take our slice, we set our bolus tracker or our ROI within the pulmonary trunk. You can also place it in one of the arteries as long as you get a really clear picture. Just know if they breathe very different and it's not in a stable location, you're gonna miss the bolus. So that's something to consider too, because these vessels will move some or if the patient's moving. Okay, all right, so we'll come down to monitoring and we'll talk about this one. This one's different. Remember on the chest, it was 10 seconds. On this one, it is 2 seconds. All right, so essentially, I'm gonna set all this up, get my ROI in, I'm gonna give a saline flush on my power injector, and then I'm gonna say, okay, here comes contrast. I'm gonna hit both of these buttons here. Let me show you. I'm gonna hit this button, which starts my injection, and I'm gonna hit this button, which starts my scan. All right, then the scanner is only gonna count down 2 seconds, which is like the minimum it can count down to be prepared. So it's gonna go really fast, all right? Now, notice if we look over here, it went 1, 2 seconds, and then it took one picture, and it was already enough to trigger the scan. That's how fast it happens. Remember on the chest, we were at 23 seconds before we started scanning? Well, on the pulmonary embolism, we, let's look here. If we go to this, the countdown on this one is 6 seconds. So it went 1, 2, picture, 3, counted 6 more seconds. So this scan began 9 seconds after pushing the contrast button, right? This was going in at 6 cc's a second. You only get one shot. It happens so quick that sometimes my stomach hurts, right? Because I've had a lot of extravasations. But as long as you do it right, there's nothing to worry about. So let's see if we got a diagnostic PE. It triggered. And just so you know, the PE triggers at actually, instead of 100 like the chest, this PE on the P3T protocol actually triggers at 20 Hounsfield units. So it's incredibly fast. All right, so if we come over here, let's look at what we got. So it's gonna look a lot like your regular chest that we just did. But notice the difference. On the chest, the vessels were not like the arterial vessels. This is our aortic arch here. It is bright white. It's as white as bone, right? So we're in the arterial phase, whereas the chest is not in an arterial phase, not so much. It's kind of between arterial and the portal venous. It's still pretty early, but it's not arterial anymore. So here we are. Here's our pulmonary trunk. There's one branch. You can see it beautifully. And here's another branch here. This is a perfect PE study, okay? And these are the pulmonary veins returning here and here to the left atria. And then that'll drain into the left ventricle. Then the ventricle will push out and up right through here into the ascending. Anyway, you guys are gonna need to study all that, but I can nerd out on it and look at it. But this is what you're looking for. These bright, beautiful trunk here. And then the vessels. And the rad's gonna look at this vessel and just follow it out and look for where the contrast goes black. This person doesn't look like they have a PE. A lot of times the patients that are incredibly symptomatic, their ears are turning purple, they can't breathe, they might be dying, right? Because PEs can be fatal. Those are gonna have big blacked out chunks right here through this area, and that's a very obvious PE. I say that to you because a pulmonary embolism, just like a brain bleed, is a critical result. Okay, so if you're working an incredibly busy schedule, say you're doing a ton of outpatients, they order an ERPE, you're like, just another one, man, that's all they do is order them, you're frustrated, like put yourself in that frame of mind and then recognize, oh, and this patient has a PE. If you don't catch that and you just put them back through their regular workflow without contacting your radiologist, that rad may not prioritize it either. So it is your job on critical results like brain bleeds and life-threatening things like PEs, that you can see that, talk to your radiologist and say, hey, Mr. Doe has a suspicious pulmonary trunk or right pulmonary artery, so on and so forth, right? You communicate that so that they can prioritize that, bump it up, and get that result to the ER and the patient can receive the care they need. Anyway, so it's a critical result. Make sure you recognize PEs. Google them. Once you've seen a couple, they'll be pretty obvious. And when you have this much contrast in the pulmonary arteries there, they are easy to see, okay? All right, let's go through. We talked about that. These are 3 millimeters. Can you see that there? Yeah, 3 millimeters. Again, this acquisition is different. Now we're using 128 detectors. We're using the entire detector array at 0.6 millimeters. Okay, as small as we can get. That's because it's so fast. If we look at the scan here, the rotation time. So we are spinning the tube around that gantry in 0.3 seconds. Around that gantry in there. So that whole mechanism is rotating at 0.3 seconds. 360-degree rotation. That's insanity. That's really fast. If we look over here, we can see our pitch is 1. So there's no overlap. It's just straight through. The scan time for this is only 2.33 seconds. All right, so this whole thing takes what, like 11 seconds to complete, maybe 12. That's insane. Like from the time that you start your monitoring to the finish image, which is up here, 11 seconds. That's impressive because we used to have 45-second PEs when I had a 4-slice GE. All right, if we look at the reconstruction tab, I think this is the same window as our regular chest, if you remember. Our kernel and our window are the same. Notice down here in the comments that we're using Omnipeg 350, but we've kind of talked about that. Let's go over here to our coronals. So on our coronals, these are really pretty as well. And I've seen lots of variations of these, but look at how bright that is compared to the chest, okay? We can see gorgeous arteries. Look at the trachea here, the air-filled trachea here, down. We can see the bifurcation, all that. So these are great. These coronals, anytime you do a coronal on a pulmonary embolism study, you're gonna do a MIP, a maximum intensity projection. Let's go ahead and jump into this here. So a lot of facilities do different things. I've seen many facilities do many different things. Like for instance, if we look at this slice here, this center slice right here, this is the right pulmonary trunk, right? So we could do a cool reconstruction through there. These are called obliques, right? So if I zoom in a little with my field of view, I'm gonna align the access straight through that pulmonary trunk. So I'm gonna go from the trunk here, kind of through that whole right lung there, and we're gonna be able to follow it down. It's gonna stand on end. Another cool protocol you can do on these is you can do really thick slices. So we're gonna do 10 millimeter slices. Now those are gonna be super high signal to noise, right? And then, but what we're gonna do is we're gonna mess with the increment. We're gonna do a 2 millimeter increment. So what we get is 8 millimeters of overlap with each slice. So we'll go ahead and run this recon and see what we get on that. Let's make sure it's all gonna be covered. Yeah, it's all there. All right, let's see what we get. Reconstruction. So we'll do that real quick. Take a look at what we get once the computer spits that out. And then guys, that's really the PE. Again, in the recon tab on this, notice it is just under MIP thin is what it's using. The algorithm does change a little. Or the kernel's the same, but the Windows CT angio, right? Which is gonna give you a sharper image. It's just and inherently a little noisier because it's sharp, but not so bad. Like if you look at this MIP, again, like I said, it's really pretty. So we'll let that spit out. We'll stop this and we'll jump over to an angio chest, and that'll kind of be the end of this lecture. Hopefully you guys are finding this a little bit helpful. There we go. There's our recon. Let's see if we can't put that vessel on end. All right, so we're in the heart here. So as we come out, here's our pulmonary trunk facing us, right? So it's right on end. So if there was, look at that. So like we're looking down the lens of all of that entire pulmonary tree. Now, I brought this up to my rads, but they were used to what they were reading. They didn't want it. I saw this protocol on a site visit down in Texas when we were trying to buy a scanner, but look at that. It's right there, and then every branch. So if you saw a clot, you could follow it pretty easy on this, but that's an oblique. So, you know, if you want to run it by your rads once they trust you, you can see what they say. All right, so there's our PE protocol. Hopefully some of this information has been helpful. We'll jump over to the angiogram, or the specific CTA of the chest for the aorta. All right, guys. So for this one, our system deletes deletes all its raw data after a while because it starts to get full. So I don't have CTA of the thoracic aorta on my scanner, but I have kind of the next best thing. So I'll go through it and I'll explain the difference there. But the fundamentals of this is the same, because this is an aortic angiogram, except it's a runoff. So this one's scanning from the aorta through the toes, which is insane. So if you look here, we're gonna go aorta to toes and look at all the vessels in between, which that's a pretty cool it's a pretty cool scan. And the fundamentals of the scan are the same as the chest. But like I said, these aren't as common, right? We don't do as many, most thoracic dissections or aortic dissections just aren't as common as a PE or a pneumonia or a cancer, okay? All right, so again, we'll start at the top of the topogram. Now this topogram is wrong, but we'll still start there, okay? Like imagine it was a chest. I'm gonna rig it up and see if I can't make it look like that. I can't. So they started at the abdomen, like they would for an abdomen. Typically you're gonna do just like a chest like we did last time, right? And we're gonna bolus track in the carina, just like we did for all the other chests. But I pulled up this protocol because it's got some specifics on it. But anyway, we would bolus track up here at the carina. But look at our premonitoring slice. This is what matters. It's the descending aorta. Now, it's the same, that's the same as a regular chest, right? So then what's the difference, right? Maybe you can guess it while I ramble for a second. The difference between a regular chest with contrast and a CT angiogram of the chest is what? Well, on the regular chest, we're not, remember what I said on the last section, is on the regular chest, we are not in the arterial phase. We're like between arterial and like portovenous, okay? So it's just out of arterial. So for this one, we need to be specifically in arterial. And there's a couple factors that can go into that. One is gonna be the flow rate, the injection rate. And this is, I failed to mention this previously. On a CT chest with contrast, our injection rate is 3 cc's a second. On the CTA, it's 4, okay? And then on the pulmonary embolism, I showed you the P3T protocol, and it can vary per patient and size. So on this one, the CTA of the aorta, we are going to inject at 4 cc's a second with Omnipaque 350. But we're still bolus tracking here. So one of the combinations is the flow rate. The other part that's going to change, even with the same bolus tracking, is this tab. All right, so we're going to do a 10-second delay again. The countdown there. But this one should be faster. 10 and 3. Oh, sorry, y'all. I freaked myself out for a second. So on the chest, so I went back to check. So on the chest, yeah, it's 10 seconds on the monitoring. So it counts down 10 seconds after you start the scan. And then on the regular chest, it counts down another 10 after it triggers, which puts you like on that last scan, it put us at 23 seconds. If we look here, we bolus track and it counts down 10 seconds before it starts. You guys can see that there, right? On the monitoring one here, we've got a 10-second countdown. So we start our contrast and our scan at the same time. It counts down 10 seconds and takes a picture. The first picture there is, it's measuring 0 Hounsfield units, so like blood or water in the descending aorta. As we continue, the next picture is 21. The next one's 10. That is a good thing to note. Do you see that? We go from 21 down to 10 again. So what could cause that? an irregular heart rate can screw with your bolus tracking, right? And not just the heart rate, but an irregular ejection fraction. Like if they are inconsistently pumping blood, if they have arrhythmias, AFib, something like that, it's going to screw your bolus tracking all the way up. So we go from 21 to 10, then we go to 41, and it looks like we're going to start consistently going up, 71, and we trigger at 100. Right there, okay? So we set our trigger, we go. At this point, we're looking at, say we got 6 images, and we did 10 seconds, so we're at 16 seconds, and then this is the difference right here. This is the difference between the regular chest and the angio. This is a 3-second countdown instead of a 10-second countdown. All right, so that 7-second difference gives you an aorta that looks this bright. Crazy bright like this, okay? As opposed to a washed out chest. Now notice this looks more like a PE study than just an angio chest. A lot of times on an angio chest, your pulmonary arteries will already have been cleared of the contrast because it hits this first and this second. Usually you don't get dual enhancement like this, but hey, we got lucky, right? All bodies are different. But, all right, so we'll go back to, let's look at the protocols now. So we triggered, we started our scan, we scanned. Remember, this is a CTA chest. We scanned from above the aortic arch, typically down through the renal arteries is where I go for that, which are going to be like, down here somewhere. I'd probably watch my scan and just stop it right there, right? Those are our renal arteries. So I'll get those because you're going to do these pretty little spins when you're done. All right, so we get our images. Let's look through some of this stuff here. We got 3mm slices, 95 cc's on this. On a CTA chest that's not a runoff, it's probably 80. But this is gonna be the same. So this is weird, right? We're at B30S very smooth. Remember, it was B30 for all the other ones, and this is on an abdomen. So take this with a grain of salt, since I don't have my protocol for the other one, that this isn't really counting. I just wanted you to be able to see this. So we're gonna pause, and I'm gonna jump into an emergency patient where I pull just the angio protocol. All right, so I decided to change things up mid-talk. Since I do not have an angio chest patient currently on my scanner, we're gonna talk through this protocol. And since you've seen enough of the chest x-rays, or the chest CTs, I think now you've seen what the topograms look like, we can do this without the images. And you can use the previous, or the next video, depending on what order I sequence these in. You can use those images as a kind of reference to see how bright the arterial vessels are. All right, so we do our topogram. This is gonna look like the chest. We'll set up our scan. One thing I want you to note, different on this, as this is sequenced, on angiography, not PE angiography, but like true aortic angiographs, you have to do a without and a with. The reason is you want to see the without, because if they do have a dissection, you want to be able to tell how to compare the two, okay? Like the false lumen, the real lumen, and all that. So you have to have a without and a with. So the scan of the without chest is just a regular chest scan, okay? Apices through the lung bases. It's going to be like 3mm, just like kind of everything else, and the reconstruction looks like every other chest we've done, right? Okay, so if we go to the angio, same thing here. All right, 3mm, all that. Let's look at the timing on this one versus the other one, okay? So we set our pre-monitoring slice. We're gonna put that in the descending aorta, which the other video will reference for you. The monitoring, it's a 10-second countdown with a 6-second delay. So the angio chest really only varies in protocol from the regular chest width by a 4-second count. So that doesn't seem like a lot, but when you start thinking about like how fast the PE has to go and all these things, like a few seconds makes a huge difference, especially when we're talking about trying to capture contrast-filled arteries. All right, On this, this protocol is set to 95 cc's for the angio chest. Okay, so that's what we'll use. Let's look here. Our acquisition here is just like our regular chest. So this is basically a regular chest with Omnipake 350. Yeah, and a 4-second difference in our delay. That's it. Let's see where it's set to trigger. We don't have that set up, so I can't. Let's see where the trigger's set. Yep, at 100 Hounsfield units right there, and that's adjustable. Like, you can click it and change it, but it's set to be at 100. This is kind of hard with no images, guys. I'm gonna be honest. We do MIPS, we do spins. So I'll tell you what, I'm kind of at a loss on this one with what we got going on. So I went to dig around on packs so I could find you at least a version of a CTA. All right, remember the way the protocol is set up, okay? We end up with a without chest, which is a regular chest, and then we do a with chest in the arterial phase, right? And the bolus tracking makes that specific. We do a 10-second countdown, and then there's our delay. Then there's our monitoring, and then it triggers at 100 Hounsfield units. There's another countdown, and then bam, we're in the arterial phase, and we scan. So here it is. This is the angiogram of the chest. So we have our aorta, bright and beautiful. And this is what I was commenting on here, on like the difference between this and a PE. Okay. Now, on the PE study, remember, we're focused on having the pulmonary arteries bright, right? But look how washed out these are. Right, so we don't see these as pretty, and I think honestly for a PE to be diagnostic, the Hounsfield units need to be at least 400. I don't know what they are here, but anyway. So if we look here, look at the aorta. The ascending's beautiful, the descending's beautiful. So if we follow that down, we're trying to get that all the way down, right? And then bam, there's the renal arteries, and that's where it stops. Okay, so this is a CTA of the thoracic aorta, and I just wanted you guys to get a chance to take a look at that. If you look down here in this corner, this is our it's B30F smooth. That's gonna be the kernel, and then again there's the window that it applies, which I don't remember while I'm showing you this, but you can reference earlier in the video. So that's that. On the CTAs, anytime you do true CTAs or true angiography, when I say true, I mean not PEs. Whether it be the circle of Willis, whether it be the carotids, any portion of the aorta or runoff, you're always gonna do fin reconstructions and then do like a MIP spin. Like I showed you on the previous video when we did all those cutouts on the angiography, you do the same thing with the aorta. And so you get this beautiful like umbrella from the ascending to the descending and down, and then you spin it on an axis, and you get these gorgeous pictures. So that's the gist. So I'm gonna figure out a way to put all this into a somewhat coherent format for you guys, so you can kind of you can just take something to chew on, a little bit of additional information when you start doing your thoracic protocols. Yeah, so hopefully you find this helpful. Again, there is so much information to know about computed tomography. You know, on your road to do this, passing your registry is obviously like the first benchmark, right? So you finish the class, you got your structured education, you get your clinical exams if you don't already have them, you pass your registry, you still have another couple of years of learning on the job before CT is really something that you're like, okay, I get it. You know, if you're a quick learner, maybe you can do it in 6 months and you'll be proficient. But to be an expert at something like this, that's this robust and this varied and this changing, it's gonna take time. So if some of what I'm saying seems like it's too much, or it's all over the place, it's because that's just kind of the nature of this modality. And I'm trying to fit all these thoughts and all this information into relatively short period of time that's digestible. But that being said, watch the video, read your book, look at this stuff, and let your mind be engaged in such a way that you can bring some questions to me, okay? Because I'd like, again, like I said in the announcement, I'd like to have a Zoom meeting where we kind of discuss some of this, because this is really like the meat and potatoes of the modality. When we get into the scans, when you start knowing the anatomy, and when you can start looking for pulmonary embolisms and you can find them so you can save a patient, that kind of thing. So I want to talk to you. All right, so you guys have a good one, and I'll talk to you soon.